have the two regulatory chains and two essential light chains over here. So what happens is, you should understand that your cells, your myosin, it gets regulated, the speed with which it does the cross-bridge cycling and the power stroke, and that's the job of the regulatory chain, to determine how fast it works. And the essential chains are there because if you don't have the essential chains, they won't be any cross-bridge cycling or power stroke, and that's how it is. And this is the ATP binding site, which ATP binds to and gives its high energy phosphate bond energy to cause the cross-bridge cycling and the power stroke to take place. So a little bit of clinical aspects also, or before that, let's just talk about some more proteins which I may have missed. So there are other structural proteins that help in organizing this crystalline lattice structure of the muscle. And what is that? So I spoke about myomycin already, which was in the M line. Now, if you look at the Z lines, they are composed of proteins called alpha-actinin and cap-Z. So you have the alpha-actinin and cap-Z protein over here. This makes up your Z line. And then we have you noticed that you have so many actin and myosin thin filaments and thick filaments, and they don't get tangled like your hair in the morning? Now, why is that? Because you have this protein called titin, T-I-T-I, and it is the largest protein in your body. It's around 3 million atomic mass units in weight. So, and it extends from one Z line all the way to the next Z line. This acts as a scaffold. It's called the scaffolding protein. Because when you build buildings, you lay a layer of scaffolding for the so that the workers can come and work, and they maintain the shape of the bricks in the building and whatever. So this is your scaffolding protein, titin. Very important also to remember, and it plays a role in adding some elasticity to the muscle. So remember, when you take a piece of meat and you try and stretch it, and the muscle shows some elasticity and it comes back to shape, titin plays a role in that. Also the connective tissue and the collagen and all of that plays a role in this elasticity. Then you have another protein called tropomodulin. So what is tropomodulin? This extends, you could see this is tropomodulin in this sarcomere over here. So it extends from the thin filament over here towards the hemline. So we have the thin filament over here. This part over here is the thin filament, and this is held in place because tropomodulin is extending from the end of the thin filament towards the M line. So I'll just take that out of this one over here, and I'll just draw. So this is the thin filament, and now we have something holding it in place so it doesn't get tangled too much over there. And also on your thin filament, drawn in red over here, is nebulin. Nebulin extends along the entire length of the thin filament from the Z line to the end of this, and it plays a role in determining the length of the thin filament. So when you work out, it can alter the length of your nebulin. Same thing with tropomodulin, it also determines the length of your thin filament. Just be aware of that. Okay, so these are your proteins, and along with actin and myosin, troponin, tropomyosin, and tropomodulin, you have these other proteins like alpha-actinin, cap-Z, myomycin, and all of these titin. Don't forget these names, they're important. Then there's another important component, which is called dystrophin. So here we have dystrophin glycoprotein complex. It looks like this. You see this picture over here. So what it does is, it is a very important protein which helps to bind those thin filaments and keep them stuck to the cell membrane of the muscle. They hold things in place, and if you have a problem with dystrophin, your muscles die and they don't survive long. And this is this is called there are conditions like Duchenne's muscular dystrophy, and we'll talk about these Becker's dystrophy, and we'll talk about this in some time. So what happens is, you have these this complex. You have a dystroglycan and sarcoglycan, and they form a part of these proteins which are located here in this picture. You could see they are the integral proteins, and they're also like they come under the category of transmembrane proteins. And then you have peripheral proteins which are also associated with this complex. This involves dystrophin and dystrobrevin. So it's in red over here, dystrophin, and this green is dystrobrevin. And you have the N-terminus of your dystrophin, which binds to the actin. So your thin filaments get attached to this dystrophin complex over here, glycoprotein complex over here. So if you have a mutation in dystrophin and it gets damaged or it's not produced properly, you will actually cause the muscle cells to die quickly. So deficiency causes dystrophy. Which kind? So there is Duchenne's, and there is Becker's muscular dystrophy, and another called facioscapulohumeral muscular dystrophy. So what is this? Well, what's common amongst all these dystrophies? Like I said, you can't anchor your proteins properly over here, especially those thin filament ones. So you get degeneration and weakness of your muscles. Degeneration and weakness of your muscles. So because the muscles start to die, what happens is fat starts to deposit in the muscles. So it looks like your muscles are getting thick and strong, like hypertrophy, but this is not muscle tissue that's getting big and strong. You are getting pseudo hypertrophy. Hypertrophy means increase in size. Right? And usually you associate increase in size in your muscle with more strength, more gains in the gym, but in this case it's not happening. What's happening is your muscle cells are dying, and you're going to get more fat deposited in the muscle because of that. So in Duchenne's muscular dystrophy, you have this absence of complete absence of this dystrophin complex over here, and if it's partially absent, you get Becker's muscular dystrophy. So what is Duchenne's muscular dystrophy? It happens in 3 in 1,000 male births, and it's X-linked recessive, so it's sex-linked genetic disease, and 30% of cases do happen by spontaneous mutation. So the mutation is in the short arm of the X chromosome. You get XP665 mutation, so you get a non-functional protein. It's not produced properly. It's complete absence. So what happens is this gene is non-functional, and you don't get the protein called dystrophin produced. So this happens usually at the onset of this disease happens at the age of 4 years. So you get a kid who's got a clumsy gait. He can't walk properly. He has difficulty in standing, and eventually he'll get respiratory failure because the respiratory muscles get involved, and eventually that's how they die. Very few of them ever cross the age of 20 years of age, and there will be calf muscle pseudo hypertrophy. So the calf muscles look really thick and strong in them. And there's a sign called Gower's sign positive. So what is Gower's sign? So you look at a kid, how is he supposed to get up? He's supposed to get up, from the ground, and just stand up straight like this, and so this is a stick figure of how he's supposed to stand up. Well, what happens is in this kid who's got Duchenne's muscular dystrophy, who's around 4 or 5 years old, he can't get upright. He can't straighten his back up when he's getting up. He's going to climb on himself. He's going to climb on himself. So how does that look? I'm just going to draw in this small area. So there's a kid who's sitting on the ground over here. His hands are here. He's sitting on the ground. Now he decides to get up. So what he's going to do is he's not going to be able to get up like this over here, how I've drawn over here. Just getting up on his knees, and then getting up like this. He can't do this. So instead, what's going to happen is he's going to sort of hold his hands to his legs. These are his legs. He's going to hold his legs, and he's going to use the legs to support himself getting up. Okay, that's not such a good picture. Let's try again. So we have the hands over here, and he's going to hold his legs to get upright, because his glutes and his back muscles are weak. So they're weak. So because of this, he can't get upright so easily. So that's called Gower's sign. And then we have Becker's muscular dystrophy. This happens in 0.3 in 1,000 male births. So 3 in 10,000 male births, and it's milder than Duchenne. So they do have a better prognosis. Then you have the facioscapulohumeral muscular dystrophy. This is also known as Landausi-Girin disease. This is again autosomal dominant. It's not sex linked. Happens around the age of 12 to 14 years. And here you get weakness of the face. So they can't puff their face. Like when you're blowing a balloon and you make that puffy face when you blow. So they can't do that. Their face muscles get weak. They get this ironed out appearance on their face. And they can't lift their hands above their head. So doing overhead work activity doesn't happen for them so easily. It's very hard. And they get foot drop and winging of scapula. Okay, so this is facioscapulohumeral muscular dystrophy, or Landausi-Girin.